Good evening. My name is Ravi Mamtani. I'm a professor um, and vice dean at Weill Cornell Medicine in Qatar. And it is my pleasure to welcome all of you to our Population Health and Wellbeing series. As a reminder, the objectives of the CME CPD program that we established about a couple of years ago include: one, discuss contemporary and critical topics relevant to healthcare, medicine, and population health. Number two, examine evidence-based practices germane to public health and patient care. And number three, describe opportunities and challenges in the evolving phase of healthcare and population health. A couple of housekeeping notes. One is your cameras and microphones are turned off. Use the Q&A feature to type any questions and comments that you may wish to make. And just a reminder again that questions will be addressed at the end of the session. And again, as we've said before, this series is actually approved for CME credits, both by the ACCME in US and also the Qatar Ministry of Public Health. And so with that information in place, I'd like to remind us that the post-activity evaluation will be available in your Cloud CME by December the 15th. You will receive an email notification once the evaluation is available in your Cloud CME account. And finally, that your certificates will be available for download once you complete the post-activity evaluation on the Cloud CME portal. So on to today's exciting topic. And it is my pleasure and honor to welcome an esteemed, world-renowned hepatologist to talk to us about what I think is an exciting topic. The topic seminar is entitled Reducing Non-Alcoholic Fatty Liver Disease as a Global Strategy for Mitigating Non-Communicable Diseases. And to do that with us, we have, as I said earlier, absolutely a wonderful professional, well-known, world-renowned in the field of hepatology, Dr. Shiv Kumar Sarin. A brief introduction on Dr. Sarin. Dr. Sarin is the Senior Professor of Hepatology, Chancellor and Director of the Institute of Liver and Biliary Diseases in New Delhi, India. The establishment of the Institute was guided by his wisdom and his desire to educate, research, and support the development and implementation of clinical programs in hepatology and other related subjects. He's also the director of the WHO Collaborating Center on Chronic Liver Diseases and Viral Diseases, Viral Hepatitis at the Institute, and president, National Academy of Medical Sciences. His contributions in the development and implementation of new treatment and therapeutic protocols for liver diseases, especially variceal bleeding, liver regeneration, hepatitis B, and acute and chronic liver failure have been greatly appreciated by people and professionals around the world. He has more than 800 publications to his credit. He has edited 13 books on liver diseases and contributed over 90 chapters in various medical textbooks. He has helped develop 20 major clinical guidelines and exhibited superb leadership in various roles: President of the Indian Society of Gastroenterology, Indian Association for the Study of Liver, and Chairman of the Steering Committee of the association, just to name a few. He's also the founding editor of the journal, specifically Hepatology International. He's a recipient of many prestigious awards. The ones that deserve a special mention include Henry Bocas Medal 2017 by the World Gastroenterology Organization, Padma Bhushan by the Government of India, the World Academy of Medical Sciences International Prize, EASL International Recognition Award, Dhanvantri Medical Award, Ranbaxy Medical Science Award, and the list goes on, including some of the awards that have to do with his fantastic teaching capabilities. Dr. Sarin, as the chairman of Medical Council of India, played a key role in the development of the document, specifically Vision 2015, which had to do with medical education in India. Now, I could go on, but I would like to basically, in a few words, I'm looking for descriptors that come to mind in characterizing Shiv's contribution to healthcare. And Dr. Shiv Sarin and I go back to our days at the All India Institute of Medical Sciences. That was many years ago. I won't say how, and I will request Dr. Sarin not to say that either. But the descriptors that come to mind in characterizing Shiv's contribution to healthcare and medical care include words such as superior intellectual capacity, brilliance, clinical acumen, analytical mind insofar as research is concerned, and more importantly, his compassion in patient clinical situation and his desire to alleviate pain and suffering throughout the world. So with that, please join me in welcoming Dr. Shiv Kumar Sarin. Shiv, the screen is yours. And thank you so much for taking the time to be with us. I know how busy you are, and we really appreciate your contribution to our CME and CVD programs. So over to you, Shiv.
Thank you. Can I share my screen? And yeah, thank you for your kind words, Dr. Manthani, and my pleasure and honor to join you all today. And I bring greetings from the Institute of Liver and Biliary Sciences. And I would like to say that this request made me learn from my old friend, as I always used to, what is population health sciences. And he gave me a quick briefing on what is a population health sciences. So thank you for educating me. And I have nothing to disclose, and I'll not be discussing any unlabeled, unapproved use of drugs and products. But I have a disclosure to tell you that if each one of you want to live 100 years, you will have to listen carefully. This is a secret. All right. What are our learning objectives? You all know this, but I'll just try and briefly mention what I think is relevant.
Dr. Sarin?
And each one of you, I feel, can you hear me?
Yes, Dr. Sarin, may I ask you to please
Ravi?
share your screen?
Okay. Am I not sharing my screen?
If you could
That's
please.
not fair on my. Okay. Let me do that.
Thank you,
Okay.
Dr. Sarin.
Yeah. Okay. All right. So I go back and I tell you, is this screen better now?
If you can go perfect.
Can you see it well?
Perfect, full screen. Perfect.
All
Thank
right.
you.
So that's where I work. And my disclosure, as I told you, is to make you all better and smarter than what I am and other people are. And my learning objectives. So we'll go on again on the objectives, but let's start with the basics. This organ placed on the right side, the right organ in the right side, weighing 1.5 kilograms, is the largest immune gland. And you know that it detoxifies. You know that it synthesizes and stores. But what I want to tell you that it controls your blood sugar, not pancreas. It controls your fat metabolism. And also, there are two circulations. One is your blood and one is your bile. And believe me, bile is the most important circulation to maintain your life. And therefore, liver is the boss. What damages liver? You all know, and I know nobody drinks in Qatar. Alcohol. There are viruses. So I'm not discussing about what you already know or don't practice. What I'll tell you is about fat. What does surplus fat in the liver do? Remember, it inflames the liver and it harms other organs. So a normal liver is less than 5% of fat. It is maroon. You all know the liver color. But if it is 10% or more fat, it enlarges, slightly becomes whiter. And a fatty liver is because of more calories or your dysfunctional bad genes you inherit. And the calories and fatty liver have a direct relation with changing bacteria, and bacteria change and make your liver fatty. Let's go further. This is an important slide. So, these are liver biopsies. I know you don't see them as population people, but here is a liver biopsy. All these cells which are white are fat containing, and the other ones are not fat containing. So, this is a fatty liver. Now, the body's immune system, T cells, the white cells think, what are these big cells? Kill them. So, the all blue dots are your WBCs, which come here and kill these cells. This is hepatitis, fat induced hepatitis. How do you read it in the blood? Your SGPT or ALT is high. But every injury must get a healing, and this is scar formation, fibrosis. So, liver gets scarred, and slowly some of the livers become cirrhotic, hard, nodular, shrunken, and in about 10% you can have liver cancer, 3 to 4 times more than hepatitis B. So a cirrhotic or a cancer will need transplant, and the world over, the need for transplant goes to about 150,000 transplants a year, which is not possible. So this is the journey in the liver. And the economic cost of this, you people know very well, could be 20,000 million euros in just 5 European countries. It's a public health issue. Now let's go further. This is the fatty liver. Now the insulin cannot get into this cell, and this leads to an insulin resistance. Let's see how it does. There are two people, both are 55. Both of them have a 95 milligram blood sugar. They're very happy. Sugar is controlled. Now, this liver, all these are liver cells. This is the nucleus of a cell. So, this is a liver cell, this is a liver cell, They don't have any fat. His blood sugar is controlled at 95 with just using 2 units of insulin. He has a good dinner, but uses 2 units insulin to manage his sugar to 95. Here is another guy. His liver cells are bloated with fat. Now, this guy uses 20 units because the insulin cannot get in to utilize the carbohydrate, the fats, and other things. 20 units and 2 units, 10 times more. This is insulin resistance. So, liver cells with fat have insulin resistance. More and more insulin, your pancreas gets exhausted and you get diabetes. Diabetes is a liver disease. Let's go further. So we have seen two effects of fat in the liver. One is the injury inside the liver, ALT is high, and second is diabetes. Now there is a gentleman who goes, he gets his blood test. His blood sugar, okay, 95, but his cholesterol is 280, his triglyceride is 320. He goes to a doctor, he writes a prescription, his cholesterol comes down, triglyceride comes down. He's very happy. But he never asks from where has this cholesterol and triglyceride come? This extra fat. So when your liver is full of fat, in very crude terms, liver is full of fat, it comes into the blood. Everybody who has high cholesterol or triglyceride has fatty liver. Check your sugars, check your cholesterol, check your triglyceride. If it is high, you have fatty liver. Now, this fat circulates all the time. It will settle onto the arteries, you get atherosclerosis. Arteries are hard, you get hypertension, heart disease, kidney disease, bones get exhausted, you get cancers, stroke, and gallstone. Gallbladder stone is not a disease of gallbladder, it is of fatty liver. So here you understand how starting from fat, you have all these diseases. So fatty liver is the core to all NCDs. Don't you think it's a public health issue? So extra fat frames, inflames your liver and frames your body. Remember this phrase. Now, this is a fatty liver, and you have your adipose tissue, your fat tissue here. The adipose tissue also becomes dysfunctional, and this has a relevance. So, what is the talk between the fatty liver and this? It sends it macrophages, it sends it cytokines to the liver. Liver talks to them. So, insulin resistance, cytokines like IL-6, TNF alpha, C reactive protein, all of them they circulate. This is lipotoxicity. So, adiposopathy or a bad adipose tissue is also insulin resistant and also sends free fatty acids, and all these are activated macrophages. So, understand there is a close relation. So, let's again go back and then I will discuss further. So, excess calories or bad genes, where do they get? In the subcutaneous fat just under your skin. Then visceral fat around the viscera. This is liver, these are intestines, the visceral fat or retroperitoneal fat. So this fat is spilled over. The liver fat increases, the muscle fat increases. In fact, the lipid droplets in the muscle are worse. It goes to pancreas, it goes to your arteries, and therefore, remember, fatty liver is a multi-system disease. Let's look at how it affects. This is a study of 7 million adults, 36 studies, meta-analysis. If somebody has fatty liver, let's say 1,000 people have it, there will be 29 more non-fatal cardiovascular disease and 19 more deaths. Imagine how many people die. In fact, people with fatty liver have a greater chance of developing CVD and death. So now you see your next friend who says fatty liver, so what? Point a finger. Tell him kidney disease. You have 41% increased risk of developing chronic kidney disease. So, heart disease, kidney disease. Let's look at the cancers. These are 10 studies of 182,000 individuals. 25% had fatty liver. They were followed for about 5.8 years. 1.5 to 2-fold increased risk of esophageal, stomach, colon cancers, also of lung, breast, gynecological, or urinary cancers. So, inflammation of the liver reflected by high SGPT or ALT is a premonition, it's a prelude to developing other tumors. So let me summarize. Liver fat precedes diabetes and heart disease by 15 to 20 years. This has been proven by the Framingham studies and many Swedish and other studies. So, what are the solutions? If you have fatty liver or your friends, prevent development of diabetes, blood pressure, heart disease, CKD, cancers. Give time to liver. But if you already have diabetes, BP or heart disease, you can reverse them by reducing liver fat. So, my friend, tell me if I'm wrong in saying biggest public health issue today is fatty liver and the NCDs. I would like to join hands with the Population Health Science Institute, and if they like me and you would like to work with you on this issue, let's go further. Metabolic syndrome. We say very easily metabolic syndrome, but I'll redefine it for you. Fatty liver is the core. High BP, CVD, lipids, bone, diabetes, CKD, and polycystic ovary for young girls. And those who snore. It's not a fight between husband and wife, it's just obesity, sleep apnea, dementia, Alzheimer's, stroke, all are related to this. And of course, as I told you, cancers. I will now touch a little bit about obesity. First, let me summarize this part. One, liver controls your metabolism. You know it, but add sugar and fat are controlled by liver. More than 10% fat, fatty liver. Fatty liver precedes as well as contributes to all metabolic diseases, and it is a core. I have covered with you, I hope, simply liver, fat, and the body, and the mechanisms and etiology of NAFLD and incident NCDs. Let me now discuss the prevalence and how do you diagnose. So this Nature review, now it has become worse. In 2018 showed countries which have 30 or more percent of population with fatty liver. Now, India, of course, has 30%. I'm not sure where Qatar is. I know where it is, but I don't want to point out. But all this area is also red, so somewhere around this region, everybody, whether it is Bahrain or it is Middle East, whichever, I think there is a problem. All right. I have some Indian stats. On 21st November, 1.4 billion Indians were there, above 1595 crores. We use crores. Fatty liver was in 43 crores, and between 15 to 24, it is 230 crores. It will be close to, I guess, 230 million people in the young age. All right. So, what is the risk of fatty liver in the young? See, they all look healthy, and I'll come to it in a minute. So, we did a survey of 12,000 students between 18 to 21 years. Can you believe 31% were at risk? This has not been published. This is part of our national program. We run it. Stronger India through a million health educated students. 11% were already sick. 19% were borderline. Only 69% become 30. You will see that. So we need to be careful. Now, this is the data which I want to show you. Liver cancer due to fatty liver. Liver cancer is the second commonest cause of cancer deaths in the world. Now, countries where out of 100 liver cancer patients, 35 or more are due to fatty liver, are shown here in maroon. Some countries are close by. Now, this is our WHO Center's data published last year. Of 2,600 liver cancers, 39% were because of diabetes. Can you ever think diabetes and liver cancer? Yes, it's the number one cause of liver cancer today. This is what we published few years ago, where this was based on data till 2010 to 15 or so. India was having close to 10% or so cirrhosis. Today, I would say the fatty liver may be cause of 25% of all cirrhosis. And liver cancers, I already showed you. Now, this is an important slide. This is where we wrote a review for Nature last year. Now, a person is lean or normal weight. He is not obese, but still has metabolic dysfunction. The countries where 30% or more normal weight people are still unhealthy metabolically, India and many other countries are there. So, this is the global prevalence of lean or normal weight MAFLD. And I will share and I want your rebound questions on this. All right. So the obesity now, I'm sure you are aware of it more than me, are one is obese, BMI is 30 or more, overweight is 25 to 29 or so, and normal is 18.5 to 25. But in Asia, less than 23. Now, I'm not saying about the guy who is obese and is still metabolically healthy because his visceral fat is less than subcutaneous fat. You remember where I showed you visceral and subcutaneous? But I'm interested in this guy. This guy is normal weight, lean and thin, but is unhealthy. His visceral fat is more than subcutaneous fat. He has insulin resistance and his muscle mass is low. Please remember this picture. Let's go further. This is exactly that person. So these are two people, one BMI 22, second BMI 22. Both have same BMI. This guy is healthy. This is the previous one I showed you. Red shows you muscle. All this is muscle. Green is subcutaneous fat and blue is your visceral fat around kidney, around pancreas. This is your visceral fat. Now with the same weight, same BMI, this guy has so much of visceral fat. It is almost, you can see 5 times more than this guy. His subcutaneous adipose tissue is almost 5 times more. All this green, but they both weigh same. Hey, these are lean people. People say, oh, he was just 25. He got hypertension and at 30 he died. But he was never obese. He was lean and thin. Let's go further. This is seen by a simple machine which is called body composition analyzer. Now pay attention to this. This guy is BMI is just 26. This is normal up to 25. He's just slightly above. But let's say his muscle mass, segmental lean analysis. Muscles, left leg is gone, right leg is gone, trunk is gone, left arm is gone, right arm is gone. He is not normal muscle. And his fat, normal percentage body fat should have been 20%. Is this 40%? Proportion of out of 100 grams of his body, 40 gram is fat, it should be 20 gram. Now let's go further. Where is the fat? It is 100. His fat is around his tummy, 37% more. He has to reduce fat by 18.7 kilogram. His weight is not that much. And muscle, he has to add 7 kilograms of muscle and lose 18.7 kilograms of fat. If you understand this, you will realize BMI has little meaning, especially in lean people. I hope I am able to convince you that it is the percentage body fat and the amount of muscles that you have. So now there are three people. Every foodie is not bad. You can eat well. Here is a guy, and I give you an example of a lady I saw today morning. She was 77 or so, and she was weighing 80 kg. And her parents and every son and daughter were very worried. This lady was going to US tonight. But she was perfectly all right. She was this type of a patient. First generation. Nobody in her family before her was unwell. She could eat, she could handle environmental factors. But here is this guy I showed you, the lean and thin guy. He is lean and thin. He is genetically predisposed. He has no margin to add weight. Even his normal BMI is more for him. So these are three patients. One is healthy with parents healthy. He can be unhealthy. Next child can be unhealthy. But the third one will become sick. This is called walking gene theory. So remember, every foodie, every fat person is not bad and every lean person is not healthy. Look how Mona Lisa could be painted. This is by Fernando, Mona Lisa. She still is Mona Lisa, but she has been painted like Pope. Every fat person is not bad and every lean is not good. If you remember this, 30% at least in India, lean are still unhealthy. Now, You all have to become master clinician today. How to know you have NAFLD? Very simple test for fatty liver. You have to learn and teach everybody whom you have seen or will meet. Self test. If you have a family history or you are yourself obese, diabetic, blood pressure, heart, kidney or liver disease, cancers or polycystic ovary, you have fatty liver. Second, your weight. For males, remember the formula height minus 100. If you are 170, your weight is 70. If you are female, you have height, you have to remove 105. So your weight should be 65. But in case you have a family history, you have to subtract 5 more. So 170, your weight will be 65 if your father had diabetes or obesity. And for female, 170, you will be maybe 55 or 60 kilograms instead of 65. Now, simple test, you all can diagnose. A simple ultrasound, which will pick up 40% or so. A fibroscan may pick up another 30 to 40%. You can still miss. How can you confirm? Ultrasound, fibro, blood test, ALT. Now, everywhere ALT or SGPT is 40. I would say please keep it 30 for men and 19 for women. High lipids, fatty liver. High sugar, fatty liver. Let me now give you this very simple figure. You can keep it on your table. Suspect fatty liver. You don't have to go to a doctor. You can do it. Diabetic, fatty liver. Overweight or obese, fatty liver. But now you are lean. That's a problem. Your BMI is less than 23. Can you still have fatty liver? Yes. If your waist is more, if your BP is high, your triglycerides are more, your A1C is high, or you have a family history. Please remember this. You, as a population health expert, just remember this single chart. Suspect, test, detect, manage, and reverse. Let's go further. How do you do your waist? I know all of you know it, and please excuse me for overstretching it. Waist and hip ratio is one of the finest ways. It should be 0.7. Males less than 90, females less than 80. Learn and teach. Do not fit genes onto you. Fit into the genes. Don't buy genes which are more than this. Fibroscan is a simple ultrasound. It sends sound waves into 5 centimeters deep and it comes back. Takes 1 minute. We do close to 35,000. We have 5 machines. Now let me explain you the principle of this simple machine. The sound wave goes, it is attenuated. Attenuated. It is called controlled attenuation parameter, cap value. Now, if a cap should be less than 220, if it is 250 and above, you have fatty liver. Above 290, 30% liver is fat. If you take 100 grams, 30 grams is fat. This guy has 30 grams plus fat. He cannot be a donor for a liver transplant. Here is the time in milliseconds. Harder the surface, faster the sound. Normally, it should be 60 milliseconds. Here it is 40. It should be between 3 and 5. Anything above 6 is not good, stiff liver. Above 8 is stage 2 fibrosis. This guy has fibrosis stage 2. He needs further workup and maybe biopsy. So in 1 minute, you find out how much is the fat and what is the impact of that in fibrosis. Now, if fibrosed liver, this guy has fibrosed heart, his kidneys has fibrosis, he has lung fibrosis, every other organ is framed. So how do I move further? For moving further, I am in the periphery. Public health comes there. Now, in primary health setup, I will just do a simple test, FIB4. What is FIB4? Age, AST, which is SGOT, SGPT or ALT, and platelet. All of you know the relevance of FIB4. If FIB4 is less than 1.3, you are okay. And if FIB4 is above 1.3, you need much more to be done. And many people have FIB4 which is high. You then may need to do NFS, the fibrosis scoring, but don't worry, I will only do FIB4. Now, if FIB4 is high, I will send him to someone and get the risk assessment. Then you might need a fibroscan. Okay. Now, this is our protocol, and there are better protocols, I'm sure. So, a person who is diabetic will get a fibroscan, who is obese will get it, metabolic syndrome will get it, or metabolic dysfunction associated fatty liver will get it. Now, fibroscan is less than 8, he is low risk. He can be managed by lifestyle modifications, and I see Professor Mamtani is also chair in lifestyle medicine. So he will be handling all these patients. And here, those who are liver stiffness is 8 or above, they might like to manage but may refer to a specialist to handle whether he needs a liver biopsy, whether he can develop cancer, or does he need new drugs. All right. This is simple. Now, this is an important slide. Diabetes is less than 5 years or 5 years, or diabetes is more than 10 years. Now, if somebody who is, let's say, 50 years and is diabetic for 10 years or more, his risk of having fatty liver and liver related events like cirrhosis, cancer is 6 times higher. And mortality because of all causes that includes fatty liver, diabetes, cancer, heart disease is 7 times higher. So remember, fatty liver and diabetes, they are very bad. So let me summarize the second part of it. 1 in 3 adults to 1 in 5 children globally have fatty liver. It's the commonest cause of liver cancer. Overweight, obese, diabetics, lean with a family history are your suspect. Teach everybody, and public health can use this simple approach of self-test. Above 1.4, FIB4, refer to physician. They can get an ultrasound and fibroscan. If it is above 8, they can refer to a liver guy. Now, the last and important part, where I have to learn from you, but what we have done, I will share with you. National programs and global strategies to reduce the burden of NCDs. One more time, India contributes 1 in 5 deaths globally due to liver disease. This may worsen. What efforts have the country done? So we were able to convince our planning commission called Niti Aayog, and we were able to propose to the government of India in 2020 and the government announced integration of fatty liver disease into the national program in February 21, and they released the first operational guidelines in the world, and that made India into the top country out of 102 countries. India became numero uno, followed by UK. But we were given that in the preparedness for fatty liver, India has taken the first stride. And this does not mean we have achieved. We have miles to go. We have implemented the fatty liver screening to prevent the burden in 1 decade. So that was our first paper in Lancet Gastro, and then the subsequent this October is where we are in 2 years' time. This is by Dr. Lazarus, and he has given the research priorities, which I'm sure as the institute you might like to take all across. The human and economic burden, I'm not going into details, defining and implement models of care, patient and community perspectives, education and awareness, treatment and care, and above all, requesting you leadership and policies for fatty liver disease and public health agenda. All right, what are the strategies? Fatty liver awareness, lifestyle changes. The wellness starts from a liver without fat. Screening and early detection. Screening is just by self test and then you go further. Timely, affordable, accurate diagnosis. I told you how you can diagnose. It's no rocket science. Simple. Affordable treatment and rehabilitation. So this is what the government of India has now accepted and is doing. It's called bottom up approach. The bottom is here. It is up. The ASHA worker is the field worker. What does the ASHA worker do? She will identify the risk factors in the village of 5,000, 10,000. Just administer self test. And she will say, oh, out of 5,000, 100 people need referral. They will go to PHC. The PHC people will further identify fatty liver or metabolic syndrome, BP or heart or whatever. Then they'll say, no, no, we need to send it to the CHC, Community Health Center, which is 100,000 people. They will do further. They refer to advanced fibrosis further and they go to the district. So the major role is of healthcare workers and nurses. And we have to see the numbers. And I'll come to it one more time in the future, how numbers will matter. But this is bottom-up approach. Let's say India has taken this initiative that by 2025, 75 million people with hypertension or diabetes will be under the care. What we propose is simple to the government. Of these 75 million people also look for obesity, diabetes, family history, and suspected people for fatty liver and screen them. What more we proposed that include fatty liver screening and management of patients as well as families. The brother, the sister, the mother, the wife, everyone. And you will increase this number manifold. Tell me if this is a good approach, Ravi, or there are better approaches than this. This was my simple, limited understanding of what you call as population health science. Now, why should you reduce fatty liver? This is a very important slide. 3 million Koreans were followed 2009 to 2013. Their fatty liver index was measured. How did they get a fatty liver index? BMI, waist circumference, serum triglyceride, and a blood test called gamma GT. It's a liver function test. Only 4 tests. Those who did not have fatty liver, but if they developed fatty liver, diabetes was twice, death was 46% more. 46% more people die if you have fatty liver development. But what is more interesting and important is that those who had fatty liver, if they lost their fatty liver, death was reduced by 17%. Tell me how many of you live 1 to 100 years? Please put up in the chat box, I want to live healthy for 100 years. I'm telling you the secret of death of aging. This is my last slide to tell you, control fatty liver to reduce the NCD burden. Vision 2035. In my opinion, more than doctors, nurses and healthcare workers have to play a vital role. This is the way things are. Diabetes is increasing, blood pressure is increasing. See here, average year, the Delhi's lost diabetes, IHD, NCDs, 31% increase. What we propose through this to the government is that how can we stabilize or decrease these NCDs? We can do that by screening and early detection. Nurses can help or all the healthcare workers can help. Stratify them. create awareness. So a nurse is more close, or a brother is more close to the people. Of course, doctors. Individuals, public health interventions are required. So what we propose in this is that we can decrease, if we decrease 2% of NCDs every year, maybe by another decade, we can decrease the number of people dying due to NCDs. Otherwise, they keep increasing. With this, I would like to thank you all for your kind attention, and I would like to be educated how the population health science people would take this further. I would have just to tell you that we have this global agenda, and this is where the countries are eating. You know how many calories they eat, 3,600 kilocalories. All right, thank you all for your kind attention, and I'll stop sharing these slides.
Well, I am speechless. I think that your eloquent discussion on a topic that has remained neglected, Dr. Sareen, um, is absolutely fantastic. And I'm already beginning to explore in my own mind possible areas of collaboration. But we can have that conversation at a later date. I don't want to bore the audience. There are about 400, over 400 people listening to you, Dr. Sareen, just so you know. But I am just simply impressed. I'm looking for other words in English language, which I hopefully will find them tonight and send you another note. But thank you so much. And my gratitude to you on behalf of Cornell, an amazing discussion. So a lot of people are appreciating what you've said. There are some questions and or some comments. Maybe may I begin with some of those comments and questions with your permission, Shiv? Uh, so, um, and we at the Institute for Population Health, as you rightly pointed out, we have a lot of interest in lifestyle medicine. In fact, we in Qatar at Cornell are the hub for growth, development, and implementation of programs in lifestyle medicine that may lend itself to the relationship that I would like to see, perhaps in terms of moving it forward with you under your direction and wisdom under your institute. So, on the one hand, you talked about the high prevalence, then you talked about the fatty liver among young people, and then you talked about how some so-called normal people do actually suffer from some of these problems. All of a sudden, my antennas go up, and I'm saying, wait a minute, where is public health in all of this? And as you nicely spoke, how could there be a marriage between lifestyle and public health and clinicians on a topic such as this? Now, that on the one hand, and then your positive spin to the picture of fatty liver, where nurses, paraprofessionals, and other professionals can play an important role, as well as the role of self-care. You basically said that, self-care, come in and we'll do it. And you know what is fascinating, Shiv? When we look at the killers, we talk about cancer, we talk about diabetes, we talk about stroke, we talk about hypertension. Why aren't we at a stage where we include what you have so nicely highlighted as a major public health problem around the world? I'm sure there are issues pertaining to medical education. There are issues pertaining to CPD, SEMI programs. But tell us, share your thoughts on this, because I think your ideas, brilliant ideas, need to be spread, and we want to work with you on spreading that. But why is the world, including the medical world, behaving the way it is, ignoring this entity completely? Your thoughts, please, on that.
Well, we were working in silos. Diabetologists will work in their silos. The hypertension, cardiovascular will work in their silos. A good physician knows his limitations. And therefore, we have lost all the internists. We have specialists. And internists would understand very well. And I think the population scientists like you would understand the limitations, the limited knowledge that we have. But to take this message forward, I will need you I was able to talk to some people and they were able to convince, but the governments don't move. And it's very difficult that the states are moving. But therefore, don't, my simple message is don't outsource your health. Don't give it to doctors or just look after. But if you can communicate this message of self-testing, it will be very good.
Absolutely. That to me is a very encouraging and a thought that certainly I'm looking forward to exploring it, maybe perhaps doing more work on it. And I appreciate that comment. So here is another challenging question. Clearly, as you elucidated and you alluded to the role of lifestyle medicine. And lifestyle medicine, to me, as I understand, includes nutrition, physical activity, stress management, sleep hygiene, which many doctors don't talk about, social connectedness, Shiv, social connectedness. If we were to bring those in, incorporate them in our day-to-day practice, we're talking about behavior. And one of the most challenging problem in healthcare, you know as I do, changing behavior of an adult. It's to me, and challenge may be an understatement, honestly, Dr. Sarin. What is it we can do to change that in a way so that it's meaningful?
Two quick answers. First, fat in the liver is a fire alarm. Extinguish. Two, exercise means sweating plus 45 minutes. Otherwise, it is warm up. Now, what does the exercise do? Let me explain in very simple words. You know it well. All the sugar that we eat goes to two places, liver or muscle. If you are inactive, all the sugar will go to the liver because muscle is not needing it. A 45 minutes of exercise will take the amount of sugar that is required for the whole day. It will burn. So your liver will never get fatty. This is a science paper 2014 that an insulin resistant or an inactive muscle, if used for 45 minutes, is going to take care of rest of the day. So exercise means sweating for 45 minutes a day, and there are no Sundays.
Thank you. That's extremely helpful. There's a question, and I see if I can this thing, but I'll read it out to you the way it has been presented to the and the comment is, of course, appreciating again. Thank you very much, Dr. Sarin, for this informative presentation. How often does a person with NAFLD be tested? I guess it's about screening or follow-up. How often would you recommend that this be done, the test that you suggested?
So let me give you two simple messages. There is a young man of 26 and his ALT or SGPT is 80.
Yes.
His first heart attack, according to the Swedish study, is at 36. He's 7 times more risky to develop heart attack by 36. So such a young man needs to have a regular screening, maybe every month or 2 months, till his SGPT or ALT comes. It is the inflammation. But there is another guy who is 70, 60 years old. He has fatty liver. Or any other guy with normal ALT or SGPT, unless it is grade 3 or cirrhosis, you can screen him once a year unless FIB4 is high. So two categories, high ALT, young man, highest risk.
Okay.
Elderly, middle age, with normal ALT, grade 1, grade 2 fatty liver, no worries. Grade 3, yes.
Yeah. Okay. Okay. That is extremely helpful. The one challenge, and I may have said this in different words, is of course for people for the vast majority of people not to know that they actually have the problem. And we know that's true even with diabetics. Many diabetics, as you know, probably 25 to 30% of diabetics do not know that they suffer from diabetes. It's not until they land up in the emergency room, they're told, by the way, you know what, you need dialysis, only to find out that they've had this problem for a long time. And I think that many people, this applies perhaps more to this fatty liver disease. They may not know that. How do we change the system, though, so that people are more aware that this becomes part of routine screening process? I guess the first response I have is, how do we educate physicians and medical doctors to make this recommendation? But would you have any thoughts on that? To me, it's such a serious problem. I mean, and we need to do something so that people who don't know that they have a problem
So
should come forward.
I showed you one slide where
Yes.
all diabetics screen for fatty liver. All those who are obese or overweight, fatty liver.
Yes.
Lean and normal, if your waist is high, more than 90 for men, more than 80 for women, your cholesterol or triglycerides are high,
Yes.
or you have blood pressure, or you have family history, or your C-reactive protein is above 2, all these people must have fatty liver screening. So
Okay.
if you are born defective, I shouldn't say defective because you can't choose your mother.
Yeah.
You're born in a family where you have diabetes or blood pressure, you can't change it. But you
Yes.
know you're born with those genes which are metabolically unhealthy.
Yeah.
So
Okay.
all those who have that family history, self-test, put it, I am on the danger list. I need more screening. My car needs tuning. That's it.
Okay. Thank you. This is perhaps a more specific question. Do lipid-lowering drugs help in preventing the fatty liver disease? Uh,
Everybody who has high lipids has fatty liver. It doesn't prevent. I'll give
yes.
you a simple example. The intrahepatic triglyceride. You're talking of blood triglyceride. I'm talking of intrahepatic triglyceride
Yes.
is directly related to your SGPT or ALT. So if your cholesterol or triglyceride is high, your liver is full of fat.
Yes.
So it doesn't prevent, it is a result of fatty liver. Don't
Correct.
go to that stage. I'll just give you one brief example. I saw a boy 4 days ago. He was 17 years, didn't have mushes. His blood pressure was 130, 108, and he was weighing 141 kg. And
Mm.
he didn't. Nobody told him that you are unhealthy. Yeah, just you're chubby, go ahead. He had never got his blood pressure checked. So for me, it is important that people know that overweight or obesity, or for that matter, that family history is unhealthy.
Thank you. Thank you. There are several questions. I'm trying to bring them together. I know we are almost beyond time now, uh, but if I may present you a specific question from somebody who's talking about, I guess, his or her mother, if I may, and perhaps we'll leave that at there. My mother suffering from fatty liver and diabetes. She used to take perfect diet and regular medication, but now intestinal infection, and doctor has suggested to do colonoscopy, um, and 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 maybe perhaps surgery after surgery effects. Any thoughts on that? I'm not quite clear, but I think um, this individual is asking if there's role for colonoscopy in a patient with that kind of a medical background. Any thoughts on that, Dr. Sarin?
People who have got fatty liver have a higher chance of colon cancers. And
Yes. Okay.
colonoscopy above the age of 50 is a good idea to get rid of these fears out of your mind. But
Okay.
more important is that she may, in addition to colon, may have very weak bones. They may be porous. She may also have high risk of fractures. She may also have a risk of cardiac and blood pressure kind of problem. So remember that first you have to handle her to get rid of, if possible, fat. There are so many drugs. I'm not didn't go into detail.
No, yeah.
And also remember, you are vulnerable. Get into
Yes.
shape.
Okay. Well, we are beyond time. I know how busy you are and where you are. You are 2.5 hours ahead of us. So maybe it's dinner time for you.
Now I have to go to ICU rounds, but
You have to
I'll
go to
try.
ICU.
I'll just
So
go.
thank you so much. And our gratitude and appreciation to you. And once again, for taking the time out of your busy schedule